Let's talk about hemorrhage. We've already defined it. Let's describe it a little bit better. Sometimes the word hemorrhagic diathesis is used, and really I kind of object to the word diathesis because it's a big confusing word that never means anything. But sometimes it's used to describe hemorrhage. If the hemorrhage has a pressure or mass effect on surrounding structures, it's often called hematoma, hence the word oma. If the blood process dissects through the wall of its vessel, and this is particularly true with arteries and larger arteries such as an aorta, they'll often use the word dissecting hemorrhage. Hemorrhage can also be described on the surface of organs or skin, especially in terms of its size. If the size of the reddish, purplish discoloration is about a millimeter, that's called petechiae. If it's up to a centimeter, it's called purpura. If it's larger than a centimeter, it's called an ecchymosis. And basically, these are just size descriptions. So the more extensive, the larger the size, with 1 millimeter, less than 1 centimeter, and more than centimeter being the boundaries. However, clinically, a really smart person once told me that if the hemorrhage is petechial, then the cause of the bleeding is almost always a platelet problem. In other words, either platelets that aren't enough in numbers or ones that aren't working. Perhaps another name for these larger hemorrhages can be called bruises as well. Just like with water, we said there's such a thing as hydrothorax, hydropericardium, hydroperitoneum, hydrarthrosis. Well, if you sub the word hemo for hydro, the same process in which now we have blood in these cavities rather than edema or fluid or water. And of course, we said that acute hemorrhage will manifest itself as blood cells and blood products, whereas chronic hemorrhage will be breakdown of these products. Histologically, this would be manifested as hemosiderin, a golden pigment which stains intensely with the Prussian blue stain. And you would guess it stains, if you guessed it stained blue, you're correct. Let's talk about evolution of hemorrhage, because you all know when you get a bruise, it changes colors. And in the very acute stage, it's kind of a purplish red, which is, what you'd expect. Oh, perhaps after a few days, maybe a week, it kind of gets greenish, and then eventually it gets brown. And basically, that's due to the chemical changes that go on in hemorrhage. In the earliest stages, it's hemoglobin, which is purplish red, at least to the eye, grossly. Bilirubin becomes a main product after some amount of time. And of course, chronic hemorrhage now, hemosiderin is the main product. So that's the reason why purple, green, and brown generally are seen as hemoglobin, bilirubin, and hemosiderin, respectively. Let's look at some hemorrhage. Perhaps hemorrhage along a mucosal surface, like here in the colon. Perhaps hemorrhage in the form of a hematoma, causing some compression of brain, a skin bruise. And of course, if that's over a centimeter, what you'd call it, subungual hemorrhage, or a general purplish discoloration of the skin. If you think that's purple, it's recent. If you think it's green or brown, then it's more evolved with time. There's some hemorrhage in the brain. It could be subdural, it could be epidural, it could be subarachnoid, depending on causes and different things. Let's not try to define this, but you would guess if this is below the dura, it would be subdural. If it was above the dura, and almost always involving probably some skull fracture, would be epidural. If it was bleeding from a very large vessel rupture, which runs in the subarachnoid space, then you'd call that subarachnoid hemorrhage. Here's some hemorrhage in the abdomen. You can see there's gelatinous blood clots. And remember, blood clots can form after a patient dies as well. So there's a little trick we use to differentiate what we call premortem from postmortem blood clots. And of course, in the pulmonary artery, this is crucially important to figure out whether this clot formed in the lung after the person died, or not only before, but it's what caused them to die. Here's some hemorrhage along a serosal surface. Here's some free hemorrhage within the abdominal cavity. Here's hemorrhage as might be seen on a CT scan. You know it's CT because the bones are the densest structures. It might look perhaps like a tumor within the spleen. Perhaps you could see it as some disruption of a kidney. And the principle is, if the hemorrhage is denser than the surrounding tissue that it's in, it will show up as an increased density, X-ray wise as well. An MRI, on the other hand, is much better for hemorrhage because as these chemicals change from bilirubin, from hemoglobin to bilirubin to hemosiderin, they give off different signals under a variety of tweaking of the coils and the magnets. So you can actually tell chemically whether the hemorrhage is in one of these three chemicals by being a slick MRI doctor. And of course, usually in MRI, the bone is one of the least intense things, so you know this is MRI. What's the difference between a hematoma and a clot? Well, not much. They're both about the same, but remember, if a blood clot, whether it's especially a pre-mortem blood clot, has kind of a mass effect, it is generally called a hematoma. Okay, so let's go into another, let's start solidly into another topic called hemostasis. And hemostasis can be defined best by talking about what it is the opposite of. It is the opposite of thrombosis. So if you took all of the forces in the body that coagulate blood, that's called thrombosis. If you look at all of the forces that prevent coagulation, that's called hemostasis. So hemostasis are the forces which preserve the liquidity of the blood. And hemostasis is also a mechanism for plugging sites of vascular injury. Hemostasis has three main components, and we're going to get into that in the next 10-minute clip, but let's mention them now. There are vascular wall components, and that's chiefly due to the action of endothelial cells and the underlying extracellular matrix. That's also be thought of as being the earlier component, or earliest. Then there is the component of platelets doing all the things that platelets do, which we'll talk about. And then finally, the classical coagulation cascade, the changing of profactors into factors with the ultimate formation of the fibrin clot. All of the factors that lead up to it, and some of the factors after it, which either stabilize that clot or dissolve the clot, which is called fibrinolysis. So let's talk about the sequence of events following vascular injury, at least the beginning. The very first thing that happens is that it's a reflex neurogenic vasoconstriction. It has nothing to do with chemicals. It's strictly neurogenic. The endothelial cells, however, then release a compound called endothelin, which is a very powerful vasoconstrictor. Why? Because it wants to close off that vessel that's leaking. That's why. The extracellular matrix, when exposed to the blood, acts as a very, very, very powerful substance to adhere and activate platelets. And the ultimate secondary process then is the formation of a platelet plug or platelet aggregation, and that's called primary hemostasis. If tissue factor, or when tissue factor is released by the endothelium, or you get that whole coagulation cascade, we're then talking about the final formation of fibrin, the fibrin plug, or secondary hemostasis. And of course, if you think that's the end of the story, it's not, because then there's called TPA, tissue plasminogen activator, which limits that plug, and there are other processes which dissolve it, called fibrinolysis. Let's continue in another movie.